we are very happy that Telangana state is taking a lean forward in doing the webinars and case discussions and presentations. And we all are very hopeful that we all will be promoting Ilizarov and reconstruction in Telangana. So with this note, I hand over to our dynamic state representative, Dr. Akansha, and I also invite Dr. Iyer as a faculty for present this webinar. So let's all and listen this academic feast. So Akansha, please, you take over.
Good evening, sir. Good evening, everybody. Welcome to our Budding Ilizarov Surgeons Telangana Forum webinar. And today we are going to have a webinar on infected non-unions of the femur. And Dr. Raju Iyengar, who is head of the unit and professor in Nizam Institute of Medical Sciences, Hyderabad, will be delivering an academic talk first, after which we'll take some questions, followed by which we will go ahead and have a case presentation or two. And eventually we'll have a discussion, interactive discussion on those lines. So with that, sir, can I introduce Dr. Raju Iyengar, sir?
Yes, yes, please.
I'd like to share my screen, sir. Is my full screen visible, sir?
Yeah.
Yes, yes. Yes, yes.
So Dr. Raju Iyengar, sir, has done his, 1 second, sir. Just a moment.
Yeah, it's okay.
So Dr. Raju Iyengar, sir, has done his MBBS from Wardha in 1994, MGIMS Mahatma Gandhi Institute of Medical Sciences, after which he has gone on to do his master's from the same institute of national importance, and followed by which sir has done his DNB. Eventually, sir was a lecturer there for a period of 2 years, and after which he has joined Nizam as a senior resident. Eventually, sir became an assistant professor and served there from 2003 to 2011. He went on to become the associate professor there. And from 2016 onwards, sir is a professor, and he has been guiding a lot of students, including me, till date and beyond. So these are the 3 professors and the head of the units, Dr. Chandrasekhar, sir, Dr. Nagesh, sir, and Dr. Raju Iyengar, sir. So sir has always been guiding us, taking a leap forward in terms of academics, showing us the right path, and always being at the forefront in terms of conducting conferences, workshops, and small lectures as and when possible from faculty who have graduated from Nizams and who are in other places across the world. Our Ortho-Onco CME, sir was the forefront, and Manish Agarwal, sir, had come from Mumbai for that. He has always been encouraging students to present and always take the initiative in terms of being academically profound in terms of their knowledge and being very, very sharp at their skill at the same time. So this was our team at Nizams when I was a student there, and the team actually continues to grow under the leadership of Raju, sir. Sir was our HOD between 2020 to 2023. And sir has guided a lot of people in the areas of spine, for which he is a specialist. He has done more than 600 deformity corrections till date, and Ilizarov, in terms of neglected trauma and non-union, are his forte. Along these lines, sir has published 30 publications internationally, and he has been awarded the Vigneshwar Gold Medal for the best work in kyphotic deformity correction here. And he has got 2 chapters in 2 books with more than 100 podium presentations till date. So along the lines of Ilizarov, sir has a very interesting and informative article written on reconstruction of traumatic open supracondylar femoral fractures, for which he has used autologous fibular strut grafting and corticocancellous bone grafting. And this was done at Nizam's, and sir may be able to explain better along those lines. Alongside this, I would like to share that sir has always been an ardent sports person and always being at the forefront when it comes to cricket, badminton, and all other sports in our conducted in our institute when as and when they were held. And teamwork has always been at the forefront of sir's armamentarium of knowledge and beyond. So with that, I'd like to introduce Raju sir to give his academic talk.
Thank you, Akansha. I am humbled. Many of these photographs, even I have not seen them. So thank you very much for bringing them. And I'll try to make some justice to what you have told to me. Can I share my screen? Yeah. Am I audible?
Yes,
Am I audible?
yes, yes, sir.
Yeah. So a very good evening to all, and thank you for joining this. Today's talk is on infected non-union femur. This is the place where I practice, and coming to tell something about the infected non-union. About 4% to 64% of internal fixations get infected. Though this is a very big number, but this is from an authentic article, and this is increasing in lieu of compound fractures. Every day we are getting road traffic accidents, and that are going to have compounding nature, and the infected non-unions are increasing. Majority of them land up with pain, discharging sinus. You can see there is a sinus here, and that sinus is draining. That usually happens. So, and this all can be effectively managed with Ilizarov. You can see these infected non-unions can be effectively managed with Ilizarov. Coming to last month, we had an academic talk on TBI Ilizarov. Dr. Ravindranath elaborately told how tibial fixation has to be done. But when it comes to difference between a leg segment and a thigh segment, a leg segment is almost circular and it is most adapted for ring fixations. And as the muscle bulk is less, and the muscle bulk is more posteriorly. The neurovascular bundle also lies posteriorly, so that Ilizarov fixation becomes easy in tibia. The problems, obstacles, and complications are less with tibia. Though equinus is a problem with tibial Ilizarov, that can be effectively tackled by good physiotherapy and early weight bearing. And lengthening is very predictable in tibia Ilizarov. Coming to femur segment or a thigh segment, it is something like a conical, where the circumference and the root of the thigh is large, and when it comes to the knee joint, it is relatively small, and there is a all around muscle bulk. And so the ring construct hinders with the local anatomy, like personal hygiene will be very difficult. At the same time, ambulation also becomes extremely difficult if the patient is a bit obese, as both the thighs, they come together and the rings keep on hitching that. So ambulation becomes difficult. And usually in femur, primary Ilizarov are not done because of the same reason. Now, coming, what are the goals of infected non-union? When we are assigning the case of infected non-union, what are the goals? The first and foremost thing is the eradication of pain. Any infection in the body, may it be an osteomyelitis or maybe a simple abscess, it is very painful, and bone is also very painful at that area, and it has no exception for that. So one has to eradicate the pain. Eradication of infection, that is also very important, because unless you eradicate the infection, it is not going to heal. So long there is an infection, the osteomyelitis will set in and there won't be any healing process. So one has to debride it and one has to eradicate the infection. The third important thing is restoration of alignment. This is of paramount importance, because unless the fractures, unless the non-union is aligned, it won't settle for union, because the primary weight bearing axis has to be realigned. Thereby you can get union. Bony consolidation Functional recovery. Again, this is an important aspect because we are dealing with femur, and knee joint is the biggest joint, and it is a lot of hurdle is there in knee joint because once we apply a fixator, the knee usually becomes stiff unless we mobilize the knee on day 0. And limb length discrepancy has to be addressed. And Ilizarov is one such fixator which can very easily correct the limb length discrepancies. Way back in 1950s, Professor Ilizarov has given this fixator, and there are numerous advantages of Ilizarov. Like it's a minimally invasive surgical intervention. No other surgical intervention is so minimal as compared to Ilizarov. You take even MIPO technique, that's also a little bit major surgery when compared to Ilizarov. Ilizarov is purely percutaneous surgery, and we can get a stable fixation of all the bone fragment. Maybe a comminuted fragment, we can even put our wires, thin tension wires in the comminuted fragments and get it stabilized. And we can get a stable versus a rigid fixation also. The most important aspect of Ilizarov is it has the ability to control the bone fragments. Like if there is in between the middle fragments are not opposed, they also can be brought by drop wires. They also can be brought with shank spin, and so that we can derotate and we can oppose them adequately with Ilizarov surgeries. Correction of limb alignment even in post-op period is possible. We can usually do some minor adjustment even in the post-operative period also. What is more important is this surgery can give us immediate to early weight bearing. That is what is the most important aspect for outcome as well as for the well-being of the patient. The minute patient starts weight bearing, most of his problems are solved. That's why way back Watson and Jones say that movement is life and life is movement. And we can have the early mobilization of adjacent joint. This is also an important aspect in Ilizarov because unless we move the joint stiffness will occur. So we have to move the joints, and Ilizarov can help us in moving the joints, mobilizing the joints. And of course, limb lengthening is the main fault of Ilizarov, which no other surgeries can offer to the patient. And limb lengthening, once taken judiciously, can definitely help the patient. Now coming to the indications of Ilizarov. I have written infected non-union into bracket. The reason is all infected non-unions are not really an infected non-unions. What happens is whenever there is a loose implant, there is an instability, and instability anywhere in the body invites some amount of infection. Here, I want to say one thing, that all infected tissue in the thigh segment doesn't mean that they should go for femur fixation, Ilizarov fixation, because this surgery patient has to buy rather than we selling the surgery. What happens is whenever there is little bit of infection, we jump and try to put Ilizarov to the patient, and then the patient really has a lot of problems. So counseling is extremely important, and whenever there is an infection, we have to do a battery of tests to say that really the bone is infected, not the surrounding, just the tissue infected, or just the skin is infected. If the patient has a small sinus, we have to find out whether the sinus is coming really from the bone, debride it, find out whether it is really an infection, then and then only one has to jump for Ilizarov correction. Second is a deformity correction. Yes, this is a very good fault for Ilizarov. Why? Because any deformity can be excellently corrected by the Ilizarov surgery. And as I already told you, limb lengthening is again the fault of Ilizarov. No other surgery offers limb lengthening, except LRS also can do it, but it is Ilizarov primarily which gives limb length equalization. Now coming to what are the principles of Ilizarov. Here I would like to quote a small article written by Ilizarov himself. He says that experimentally and clinically a previously unknown general biologic property of tissue has been established. This was given way back in 1970s, that respond to a metered stressing arising in a mainly tension stress by growth and regeneration due to stimulation of biosynthesis. What he tells as Ilizarov effect. Very simply, it has been stated that any tissue, living tissue, which has been stretched under physiological loads will try to regenerate. And bone is the unique example. That's why we call it as Ilizarov principle as law of tension stresses. If you stress a tissue within physiological range, that will regrow, that will regenerate. That is the principle of Ilizarov. That is the law of tension stressor. It is also called as distraction histogenesis. Why this is important? Because not only bone, but even tissue like skin, nerve, vessels, everything grows under the metered stress for the tissues. That is a very important phenomena which human body possesses. The second important principle is a Wolff's law. Any tissue which is subjected to physiological stress hypertrophies. That is a very important. Why this is important is if your fracture is aligned nicely and if you weight bear on that aligned limb, then automatically bone will form there. We have a lot of regenerate, and if you make them walk with physiological load, then automatically the corticalization of regenerate happens. This is also an important phenomena which as a postgraduate we should know it. And the third and the last phenomena or principle is a Hutter-Volkmann phenomenon. This is what is called as the genesis of any deformity. So a deformity surgeon should know about this phenomena. This phenomena says that if a same tissue has been pathologically loaded, if the same tissue has been loaded pathologically, then attrition occurs. Suppose there is a medial joint line, there is a varus deformity, and you keep loading on a varus knee, automatically the medial structures keep on degenerating. That is what happens in simple osteoarthrosis of the knee joint. So this is the genesis of the deformity. Once you align the axis, once the limb mechanical axis has been aligned, the stresses, they fall back into normal position and automatic Wolff's law comes into presentation or Wolff's law comes into action. So these three principles are very important for a deformity surgeon, like what is called as a law of tension stresses, Wolff's law, and a Hutter-Volkmann phenomenon. Coming, what are the challenges in femur Ilizarov? We all know that tibial Ilizarov is a relatively a less bulky frame, whereas in femur, the frame becomes bulky because the thigh circumference is always larger as compared to leg circumference. And I already told you, there is a very little space in between the thighs as compared to legs, so that these Ilizarov rings, they keep on hindering in ambulation. The second important challenge is the problem of safe zones. In tibia, we know all the neurovascular bundle is posteriorly. So your wires can go safely in the tibia. All wire construct is very easy to perform in tibia. Whereas when it comes to femur, what happens is the medial structure harbors the neurovascular bundle, especially in the upper 2/3. So thereby putting a all wire construct usually impairs the neurovascular structures if not done properly. And second important thing is all ring construct is also very cumbersome for the patient. That's why way back in 1980, Catagni and Cattaneo, they suggested some modification called as what is called as an hybrid Ilizarov fixation for femur. This is what is in vogue in nowadays. So this is the classical apparatus which we use it in Ilizarov. You can see there are half rings, there are 5/8 rings, and there are some Italian arches. These are the Italian arches, these are the half rings, and this is the 5/8 ring. A 5/8 ring is very important in proximal tibia to maintain the knee movements. Whereas half rings, usually we connect it and make a full ring and then we use it. These are used in distal femur. And to make it more user-friendly or patient-friendly, we get Ilizarov rings in aluminium, as well as we also get Ilizarov rings in carbon frames. They are lightweight and they are radiolucent. However, Ilizarov frames of aluminium, though they are lightweight, but they are not very sturdy. So good amount of tensioning, about 130 kgs, will definitely they deform the aluminum wires, and the primary aim of tensioning the wires is defeated. So it is better to use, either if the patient is not affording, then we can use stainless steel rings, or if they are affordable, then we can think of using carbon frames. They are sturdy, as well as they also have radiolucent. These are other armamentarium in Ilizarov. This is a tapered shank spin, and this is a routine shank spin. This I will tell you in a bit detail. And these are the olive. This is an olive wire which comes very handy whenever we are doing distal femur fractures, where there are the fragments are rotated or they are displaced, so that we can reduce them, and after reduction with olive and counter olives, we can compress these fragments and get into alignment. Again, this is a typical dynamometer tensioner, which is having predicted amount of tension. But I usually use a hand tensioner, and with that hand tensioner, you can palpate. Really, you can feel by haptic sensation, you can feel how much tensioning you are going to give to that wire. And that haptic sensation over a period of time, all these surgeons, they learn. Till that time, you can use this dynamometer, and once we have that amount of tension, then there is no need to retension them. And that is how last time also there was a question, how to tension, how much to tension, and whether there is any scope of retention. I usually tension it once, and then I don't keep on retensioning it. The reason behind it, if you want to retension it, then you need to unwind the wire. For that, you need to keep the wire longer and bend it, and that bending of the wire itself will cause some hindrance for the patient in ambulation. These are the foot arches, plates for the foot arches. These are the twisted plates. These are all, they come very handy when you are using deformity correction. This is an extremely important Rancho cube. This comes in various holes, that is 1 hole to 6 holes you can get them. And these are the ones which are going to secure your threaded, that is tapered shank spin to the Italian arch. Thereby, a secure threaded pin, half threaded pin will give good amount of stability to the ring fixator. Coming to the stability of fixation, as we all know that all wire construct is a very good construct, very sturdy construct, so that there is very little movement across the fracture fragment. But we have already seen that because this is not feasible for the patient, especially when for ambulation and for personal hygiene, we tend to modify by virtue of modification. We are trading off stability versus acceptability. What happens is, when the patient has to accept this type of fixator, we have to trade with the stability. However, it has been found that model number 3, where we have two full rings in the distal fragment and 2 or 3 shank spin in the proximal fragment, tapered shank spin I mean, and then connected to an Italian arch, will give a better, you can strike the balance between stability and acceptability. Thereby, the patient also accepts the frame, at the same time we can maintain the stability. Conventional Ilizarov definitely has it's most stable versus an hybrid Ilizarov versus an LRS. And the stiffness can be increased by adding pins or wires. However, by addition of an Italian arch, what we are going to give is, we are going to give the pins about 135 degrees of angulation we can give with respect to LRS. Because in LRS, they go in only one plane. Whereas when you are giving an Italian arch, we can put the pins from posterior lateral to anteromedial, lateral and anterolateral to posteromedial. That thereby we can increase the stiffness with the help of an Italian arch. Coming, how many numbers of pins should be used? Usually a 3 pin three tapered shank pin in the proximal fragment in the virtue of a good anatomical reduction of the fragments gives excellent stability. But however, these pins should be a tapered shank pin, they should be bicortical, and at the same time they should be meticulously inserted. What happens is when we are using a tapered shank pin and we destroy the muscle by over drilling or something like that, then the pin becomes loose. Here you can see in this radiograph, you can see 16 shank pins has been introduced in a femur, and the femur has become like a sieve. You can see 8 shank pin in the distal fragment and 8 shank pin in the proximal fragment. And this many pins is going to increase the amount of infection because the fracture or the non-union has not been addressed properly. There is still a non-viable fragment seen there. That's why this went for infection. We have to redo it. Coming to the most important aspect is the tapered shank pin. This one, this is the workhorse of a knee Ilizarov femur. What happens in tapered shank pin is, if you look at the conventional shank pin, there is a shoulder here. At the shaft screw junction, there is a shoulder, and that is the weakest point. Whereas when it comes to a tapered shank pin, you can see that shoulder is tapered so that the stress distribution is uniform. Thereby, you can get a uniform distribution of stresses, and they give some immunity towards the breakage of the shank pin. I usually see that these shank pin, the conventional shank pin, they break at this junction, whereas a tapered shank pin will not break. A micro motion because of the cylinder is avoided, and thereby it increases the bending stresses. However, what we should be achieving it is all sizes of pins should be available. Whenever we are using tapered shank pin, usually they come with a paucity, so one has to have the shank pin in bulk. All sizes should be available, and we should always aim for a bicortical purchase, because a bicortical purchase will give enough stability, because more number of shank pin can be avoided and we can get away with 3 or 4 shank pin. And the anchoring should be perfect. For this perfect anchoring, stiff anchoring, I use Rancho with 2 10 mm nuts at right angles so that it gives a stable fixation. And usually I take 2 rings distally and 1 or 2 Italian nuts proximally with 3 or 4 shank pin, depending on the stability, intraoperative stability. This is one such patient. We can see that this was externally fixed with a compound fracture. You can see 3 shank pins there, and that has not gone for union. And here with the simple Ilizarov debridement, everything, we have got a very crooked, though looks like a very crooked femur. That's a united femur, and you can see so much of scarring in the thigh. You can see the entire thigh anterior segment is scarred. The quadriceps is adhered there, but still, when it comes to the knee range, he has got a decent knee range. This is the magic of Ilizarov. The minute you put the Ilizarov apparatus and make the patient walk and do the knee range, the patient gets usually a decent knee range. Now, whenever we are planning for any surgery, this is the most important aspect: patient counseling. Why I'm telling patient counseling is important? Because we all do surgeries. We think that surgery is just one part, but Ilizarov is totally different. The surgery starts after you put the frame, because this Ilizarov is a process. It is not a surgery, but it is a process. The patient has to get involved, the attendants has to get involved, and the surgeon has to get involved. And this involvement should be there for almost about 6 to 9 months till the fracture unites. And the patient commitment is one factor which is a very, very, very important aspect. And here, what I will tell is, you don't sell the surgery. Let the patient buy the surgery. You explain everything. Let the patient buy the surgery. Here, an Ilizarov, a beautiful Ilizarov was applied for a segmental fracture, and the patient did this. She just removed the Ilizarov from a private practitioner there, and she came back with this. So she was, I asked her, why did you get it removed? She told only simple thing, that I was not told this. I was not told that this is going to be so cumbersome for me. So that has to be explained to the patient. once, twice, thrice, it has to be explained nicely. And once the patient commitment is taken, then only we have to apply this fixator. The caretaker also must be involved in the process of making, so that he also gets involved. And effective ambulatory potential must be ascertained from the patient. Why this is important? Because most of these patients have upper limb problems, like they have a fracture humerus, or they have a fracture both bone, or a brachial plexus injury. You apply the frame, the patient is not going to walk. So one has to take that also into consideration. Now coming to the surgical procedure per se, you can see the important thing what comes into our this thing is debridement. That is the most important aspect. This entire fragment has to be identified. This has to be identified, and that has to be removed. So before that, what we need is, we need positioning of the patient. I usually position the patient supine with a small sandbag there, so that I can very well check the alignment of the limb. The cautery test can be performed by positioning the patient in the supine this thing. Removal of the implant is very important, because these implants are loose and there is usually a biofilm, and that has to be exteriorized. Debridement remains the mainstay there. All the particles which are non-viable has to go out, and whatever the bone which is viable has to be there, because a centimeter of bone we remove extra, that is going to get that fixator for 20 more days. That is why we have to be very careful in deciding which is viable bone, which is non-viable bone. A paprika sign comes very handy in such things. Reaming of the medullary canal. Reaming of the medullary canal is also very important, because the biofilm is exteriorized, and healing process starts early by reaming the medullary canal. These are the very simple corridors for safety. Usually, I didn't take the above, that is already there in literature. The cut 6 or cut 5, these are the very important for full rings, whereas above we usually have half pin structures. These are the cut sections for the corridors of safety. Here at distal, we can put three pins, like mediolateral, posterolateral to anteromedial, and posterolateral to anteromedial. You can use in this area. Coming to the armamentarium. Here again, I have already stated that the sizes of the pin should be available. We should use bicortical pins, and use of a sleeve. This is very important, because unless you use a proper sleeve and then drill it, you are not going to injure the soft tissues, because once a little bit of soft tissue injury there, that invites infection, because the soft tissue becomes devascularized, and once they become devasculated, infection sets in and the pin becomes loose. Today, even in 2023, I prefer to use a hand drill than an electric drill, because slow drilling is very important, and drilling by hand will prevent some thermal necrosis, and the life of your pin increases. So this is the post-operative care, partial weight bearing from the second day itself with a small shoe raise. Even if there is no shortening also, I give a very small shoe raise to the patient, about a centimeter, that flexes the knee. And just by flexing the knee, your collateral ligaments are optimally stretched, and thereby knee movement is better. If the patient puts the knee into little bit of extension or a recurvatum, that is a very bad sign to get the knee movements back. A 5-degree flexion at the knee is an optimal stretch to the collaterals. Thereby, you can very well control the knee movements and get the knee movements. Inside dressing as routine for all the cases, but a word of caution here is knee movements at the same time, prevention of equinus. Early weight bearing can take care of that, and the patient is immediately weight borne. When to remove the fixator? Yes, again, fixator removal is only after a test, dynamization test. I remove the fixator once I see a nice bone, 3 cortices radiologically. Then I just remove loosen the connecting rods, find out if the patient is having pain, and if the patient is not having pain, then I'll remove the connecting rods completely and make the patient walk. And this will ensure me that I am not removing the fixator early. 1 month later is far better than removing the fixator one day. That is the most important. Post-operatively, we can give a cast to the patient, and once after cast, we can brace them. This is one such patient where we have applied the fixator, and that is even the femur appears very scarred, but still the patient gets the movement, complete movement. This is because Ilizarov enables the patient to mobilize the knee from day 0. This is the knee movement. You can see the thigh appears scarred, the bone appears scarred, but still the movements are present. This is one such patient. You can see a lot of sequestra there, and that infected non-union, debridement, put an Ilizarov, remove the frame, and then this is the movement. You can see full movement there, at the same time full knee range. This is the wonder of the Ilizarov. Again, this was this radiograph I have already shown to you. This you can see there are so many shank pin. There are 16 in number. Removed all. It was a hard time to put the shank pin. Whenever using the previous hole for putting a shank pin, it is a big no-no for me, because even if we are putting a larger shank pin, that area is an infected area, and then that incites infection. Always try a new bone for inserting your shank pin rather than going into the old shank pin track. This is after the removal of the frame. You can see the entire thigh is scarred, but the patient is having a relatively pain-free movement. Though this patient had a lot of stiffness, but he had only 10 to 15 degrees of knee range, but his ambulation is okay. This happens when we scar the quadriceps excessively. One more case here. This I wanted to show what happens for the patient when we are lengthening them. You can see this was a straightforward comminuted fracture, and that was nailed, and 6 months later it went for non-union. I inherited this patient with this radiograph. For what we did was, I planned for Ilizarov. While doing an Ilizarov, I asked him, you will get this much amount of shortening. He said, first thing I want to walk, sir, because lengthening I will do it later. I just want to walk first. So what we did was, we wanted to dock it. So here again, there was a linear scar there. So I extended a scar little bit obliquely. The distal fragment I extended anteriorly, the proximal fragment I extended posteriorly, because once we are docking such a femur, a linear scar will definitely give you a lot of problem. Linear incision closure will be very difficult unless you make it little bit oblique on both the sides. So I extended the incision in an oblique fashion, and then Ilizarov frame was applied. On day 1, the patient started walking. That is how he's walking. You can see that there is a lot of shoe raise there. And I called him after 3 months for getting it lengthened. I said, now this is uniting, you get it lengthened. He said, no, a big no for lengthening, because he didn't want to go for the same pain of lengthening. I left it as such. See, the thigh is scarred, but he still gets a decent knee range. And this is effortless walking, but he's walking with a shoe raise. That is the problem there. Several times I called him for lengthening. He said, no, I'm comfortable. He's an IT guy, and he's comfortable with that amount of shoe raise. So again, those patients who are not willing for lengthening, or those patients who are not very happy with the shoe raise, I just tell them that you continue it. Those who come for lengthening, definitely will do lengthening in them. That is what I thought of presenting it for today. And I have a case which I'll discuss after the talk. This is a big thank you for the big gentleman who devised this Ilizarov frame. Thank you, Professor Ilizarov. That's all, sir. Hello.
Sir, thank you so much, sir. That was a very inspiring and enlightening talk.
Yes, I'm sure.
So before I start with the train of questions, I would like to welcome Dr. Milind Chaudhary, sir, Dr. Vasu, sir, PNV Prasad, sir, VBN Prasad, sir, Bari, sir, Manish, sir, and Pritish Singh sir, Ritesh Pandey sir, Aradhana ma'am, who are our EC members as well, and our faculty from Nizams, my HOD, Dr. Chandrasekhar sir, KC Shrikant sir, Sandeep sir as well, and the ex-HOD, that is VBN Prasad sir, and other faculty of ASAMI, that is Krishna Kumar Krishnur sir, and other senior faculty of ASAMI, Ranjit sir, and Ameya Bera sir. So with this, I would like to ask the first question that Dr. Wilfred Desa, who is an ASAMI faculty member from Goa, has asked. He wants to know your frank opinion regarding Ilizarov frame. Will the stability and metered stress itself help with controlling infection, or is debridement necessary as well?
So debridement is a mandatory phenomenon. See, your distraction histogenesis is not going to treat the entire infected tissue there. Debridement, I always go debridement. There is no this thing. Though Ilizarov says that the infection burns in the fire of regenerate, but debridement is a very important matter because that decreases the quantum of pain and increases the chance of union in an early period. Definitely, eventually it unites. It's a race between the pin loosening and the union. So that can be decreased by removing the debris, doing the debris.
Sir, Dr. Wilfred Desai is asking about if at all there are any precautions to be taken when doing lengthening after having treated an infected non-union, sir.
So yes, lengthening is again second part of the surgery after union or during the union. I always put the patient first because the patient has to be prepared for that. The tibial lengthening is a quite predictable this thing according to me. We can get lengthened now. Whatever the segment we can lengthen, we can get it lengthened. But femur, it comes with a lot of price which the patient has to pay. Pain is very important aspect there. So if the patient is committed, the patient is a lean, then lengthening becomes very easy. Especially if the patient is a female patient, elderly female, obese patient, then lengthening becomes a little bit more difficult. And if I had to lengthen femur, I will put an intramedullary implant and then lengthen it so that the time taken is also less for realignment and all that can be taken care of.
Right.
Is that answers the question? There are other faculty also, they can also answer it.
If anybody else would like to also contribute, most welcome, sir.
They have to unmute.
Yes, sir.
I'm Dr. Ranjit Borwa.
Good evening, sir.
Good evening.
Good evening. Good evening. It was an excellent presentation. Hi, Milind. I have just simple two questions, maybe on behalf of the postgraduate students. Which classification of infected non-union do you follow in your management of the cases? And second question, how to ensure infection-free situation in the hub of infection, that is the medullary canal? How do you ensure? Whether it is during surgery or you take some precaution to take care of this infection post-operatively?
Well, it's very simple. Post-operative pin care dressing is the routine for all the patients.
No.
Intraoperative.
My question is, intraoperatively, you do extensive debridement, trimming and everything.
Yes, sir.
In severe infections, in most of the cases. And post-operatively, and then you fix the system, Ilizarov, and you fix the bone.
Yes, sir.
Statically.
Yes, sir.
And do you think that in major serious or very serious infective cases, it will be a little beneficial that if we not fix it primarily at a time of debridement, just put one or two dummy rings, especially in femur, so that you can have a look in the medullary canal post-operatively by just relaxing your fragments, do some irrigation also at the same time. And once the medullary canal shows good granulation tissue, we can go ahead and convert those dummy rings into fixed rings. Do you, I mean, we do in that situation like that.
I do agree with you, sir. That is a very good, this thing, your point well taken. But my contention here was only simple that the maximum amount of infection, if it is removed and you get a good, this thing, then you go with the primary definitive fixation. Otherwise, what you say is perfectly all right. Depends on case to case.
Yeah, that's what. It may not be routine, but this has been, I mean, this has been developed in our setup because we had a bad experience. You fix up everything and then patients start pouring pus again after 15 days. So I think Milind can highlight on this because he has a publication on this type of situations.
Good evening, Professor Borua. Thank you
Good evening.
for remembering me. Hi, Professor Akansha. Yeah, so we are just conducting a study on our tibial non-unions. Of course, you're talking about the femur, but infected non-unions, we decided more than 25 years ago not to perform at the same stage. Debridement as well as fixation with the Ilizarov and corticotomy not in the same stage for various reasons. Firstly, when the patient has a lot of infection, there is number one, negative nitrogen balance, and that can, the negative nitrogen balance can, make it difficult for the patient to tolerate the, fixation, number one. Secondly, we found that somehow there is a lot of pain if you apply the immediately because the patient has not been walking for a long time. So what we do is we do the debridement in the first stage, then we put him in a cast or a brace, and then we make him walk. So what that does is it enables him to, get rid of the negative nitrogen balance. The antibiotics as per culture take care of the infection after the thorough debridement. He comes out of the negative nitrogen balance, he walks, so the bone develops some better trophicity, the soft tissues, and then when we put on the fixator, it's better tolerated. And recently in the tibial non-union group, we found actually that we had 4 different, it so happened because of the clinical situation, like Professor Raju said, case by case. So when we see if the patient has a massive defect or a massive soft tissue defect and a massive bony defect with infection, then what we'll do is we will debride and put the fixator at the same time, but far away, as Professor Boru was saying. It'll be far away. We will not fix all the elements, but it'll just fix instead of using an ordinary AO fixator or instead of giving in a slab or a cast. And that's our type 4. That's the most severe. Then in the second stage, we will do, the corticotomy. In most cases, what we will do is we will debride in the first stage. We'll wait a while and then put on the Ilizarov. If the infection was not that severe or the porosis wasn't very severe, soft tissue defects were not a problem, trophicity was not a problem, we'll do the corticotomy at the same time. Sometimes we'll do the debridement, we will wait, we'll put on the fixator, we will wait, and then we'll do a corticotomy. Case by case, as you said, so going a little slow at times doesn't matter. And so we have this infection severity score, which helps us to determine out of 100. It's written up in this article in IGO in 2017. It helps us to determine, based on the amount of discharge, the sinuses, the sequestrae, and, the previous surgery being whether it's intramedullary or extramedullary, like plating or just X-fix, it gives us a clue. And then the CRP and other things also give us a clue. Sometimes this infection is so severe that so you can tell the patient that you're going to need 2 debridements before we start the definitive surgery. And I have had 2 instances when I have had to perform debridement twice before surgery, then the Ilizarov for healing, and at the end of the Ilizarov, again a final debridement. So I hope that throws some light. So we can all be flexible in the way we deal with this based on how the patient presents. But doing in the presence of infection, putting on an Ilizarov, we found the patient has too much pain and there's a lot of issues, not worth the...
Sir, along the same lines, there's a question by Dr. Vidyasagar, Assistant Professor from Osmania. So during Ilizarov application for infected non-union of femur, once debridement is done, should we aim to reduce the non-union fracture first, or apply the frame first and then try to reduce? What procedure, what stage should we do first? I think that is what he's trying to.
Okay. So, so the question is, I'm sorry, I didn't get, who is the question addressed to?
Yes, sir. I'll just repeat that. So he's just asking that for infected non-union of femur, once the debridement is done, should you aim to reduce the non-union fracture first?
Yeah, I got
and
it. Yeah, I
then-
got it. Yeah, I got it. So if there is a lot of fibrous tissue, then it's not really possible for us to get an acute reduction perfectly, in the sense. So if there's a lot of fibrosis, then we're going to have to do it gradually. But if there isn't a lot of fibrosis, so when we put on the frame, ideally we do try to, get the reduction on the table, especially at the site of the non-union. But sometimes it becomes very difficult, especially in the distal femur. The distal fragment tends to go into recurvatum. And sometimes there's a lot of dense fibrous tissue in areas that you cannot reach with the debridement posteriorly. So then we do that gradually. Otherwise, we'll if when possible, when there is a lot of laxity, we will do it, acutely.
So I would like to welcome Dr. Srinivas Reddy and Dr. Prasad, who are senior faculty members from ASAMI, India, from Telangana. And Srinivas Reddy sir has just asked a question. Just like periprosthetic fractures, even with Ilizarov fixation, there's a possibility of perifixator fracture, especially in osteoporotic bones at the level of subtrochanteric region in the femur. So in cases when we restrict our fixation below the subtrochanteric level, what is your experience and what are your comments on this, sir?
So you want me to answer it?
Yes, sir.
So whenever I'm operating on a distal fracture, in general distal femur fracture, 5 out of 10 distal femurs will be in the upper 2/3 and lower 1/3 junction. So in that case, you need not go up to the subtrochanteric level. 3 or 4 chance pin you can get easily right at below the isthmus level. That is not at all a problem. But for midshaft fractures, which are relatively rare, midshaft non-unions, infected non-union, which are rare, when you are trying to put pins in the subtrochanteric area, let's not put more than 2 pins in the same area very closely, because that will irritate and that will cause a subtrochanteric fracture. It usually happens even when you are putting a very low cancer screw fixation for neck femur fractures. So that area has to be avoided. 1 pin is okay, then it will not cause a subtrochanteric fracture there. But definitely that is a possibility. One has to be aware of that situation.
Yes, sir. I would like to request other senior faculty members from ASAMI if they would like to share their thoughts on this topic. Vasu sir is here with us. Bari sir from Dhaka is here with us. So, sir, would you like to share your thoughts on this, sir?
Let me
Bari
unmute. Yes, unmute first. Now, can you hear me?
How are you, sir?
So thank you very much. I enjoyed the lecture of the Professor Raju. It's a difficult case. Now, at the same time, I'm consulting the patient, busy with the patient. No, thank you very much. Only one thing is that those who are applying Ilizarov in the femur, all the other orthopedic surgeons, including the Ilizarov surgeons, they tell all the time, this is femur, this is the cumbersome. I never agree with the other doctors, because the cases that he has shown, putting the lots of pains and other things, only these kinds of problems you can solve if you know the principles and philosophy of the Ilizarov, how to apply the femur. And that he has shown. This is my comment. Otherwise, everything is okay. Thank you very much for joining with you. Thanks all the faculties and the other budding orthopedic surgeons. And you try to the problems, you try to learn for the young generations, try to learn the proper basic principles of Ilizarov, then you'll see the results and the outcomes. And basically, big gap non-union with infected non-union, Ilizarov is the best answer for the femur. But cumbersome, those who doesn't know how to apply the Ilizarov with the femur, that is the always tell this is the cumbersome. Even the patient with Ilizarov application in the femur, they can do any kind of exercises. So day one, today you have applied the apparatus properly. If you follow the principle, I repeat it, and the fundamental principle of Ilizarov methodology is load and motion. You should have to do that one. And most of the surgeons, when they are putting the Ilizarov in the femur, they don't flex the femur. They don't flex the femur. And that's why after applying the apparatus, patient discomfort, patient is telling, sir, pain, pain, pain. So basic principles, before applying the Ilizarov in the femur, you must know that one. And thank you very much, Professor Raju and my all friends, Indians. Thank you again. See you again. All the best.
Yes, sir. Good evening, Vasu, sir.
Akansha, I saw that very nice presentation by Raju, but the criticism like the cumbersome instrument. So when you are dealing with a cumbersome problem, the results are also we have no other options. That is why we are using the Ilizarov fixator. We are not going to use it in a simple case where we can manage the other methods. Agreed. So this is a difficult problem. So the solution is also difficult. And patients should understand that the people who don't know, they will always say cumbersome. But do they have any other solutions? I always go for Ilizarov when there is no other way out.
Sure.
Agreed. So I don't mind about that cumbersome thing because originally itself, even before Ilizarov, is a cumbersome problem.
Yes, sir, definitely. Sir, there's another question from Dr. Pritish Singh. So he's asking, what is the optimal operative position for Ilizarov fixation of femur with respect to prevention of quadriceps tethering, preserving the range of movements at the knee, and facilitating the debridement, sir? Raju, sir, would you like to take that?
So I already told in that lecture that whenever I'm putting an Ilizarov frame, I keep a small sandbag underneath the hip joint or underneath the iliac crest, so that what happens is I get a neutral rotation there. External, it is not external rotated. Second thing is I just bend the knee while putting these distal wires. I flex the knee, and as sir was telling very nicely, Bari sir was telling, flexion at the knee will increase the movement at the knee. The patient will be comfortable post-operatively. He will not complain of pain. Especially the capture of the tensor fascia lata will be minimal, and it will be in a lengthened position. Thereby, the knee flexion the patient gets the knee flexion in a better way. And whenever I'm putting these wires, I flex the knee and then I apply the fixator. And as I told you, at the end of the surgery, I do a cautery test to see whether my patella, my femur, my tibia, everything is aligned properly or not. It's just putting a cautery wire and seeing whether the alignment is okay or not. Because alignment is a key for union. If the fractures are aligned, if the non-union is aligned, automatically weight-bearing axis is proper and union is certain there in that cases.
Right, sir.
Excuse me. I would like to add one point here. Akansha.
Yes, sir. Please go ahead, sir.
Actually, I have a knee flexion attachment to the traction table, and we put the patient in knee flexion attachment with the knee flexion attachment so that the TFL is pushed posteriorly. That is one way. And I have seen Professor Katani doing it in a different way. He will pass the wire from lateral side with the knee extended, and he will pull the total wire onto the medial side, and then he will flex it and repass it onto the lateral aspect, so that the TFL is pushed posteriorly and the wire will be anterior. But it is his way of doing the trick for getting knee flexion.
Yes, sir. Those are very informative tips and tricks that you're sharing, sir. I'll move on to one more question, sir, which has been asked by a student. So, how much gap should be kept between the rings and the skin? Because in the post-op period, there is a definite swelling of the thigh, sir. So, Raju, sir, would you like to give your remarks on that, sir?
Yeah, when we're applying this frame, pre-operatively, we go and check the ring size, and I preferably have 2 finger breadth all around, minimum of 2 finger breadth all around. 5 centimeter is a minimum. And if you have applied it properly, especially when you are not done any shortening, much of shortening, that is adequate. But if you are shortening it, then definitely I'll go for a larger size ring. I will not shun going for a larger size ring, because we all know that putting a larger ring decreases the stability, but you anticipate swelling, because when you're shortening it, the thigh becomes shortened. That time acute docking, you have to keep it larger. Otherwise, 2 centimeter, 2 finger breadth is fine.
Okay, sir.
Yeah, one interruption. Akansha, hello? Hello?
Please go ahead.
Akansha, one
Yes,
interruption for that. Yeah, in femur, the 2 finger breadth all around, a little bit difference. Anteriorly, it need not be that much, and posteriorly, it should be more than 2 finger breadth, what I feel.
Sir.
Because
Especially posteromedial. Posteromedial, there should be little more gap.
More. Anteriorly, you need not have 1 finger breadth is quite okay. But posterior and posteromedial, it should be more than 2 finger breadth. Many a time there will be sagging of the tissues posteriorly in the postoperative phase. Whether there is shortening, even in case when there is no shortening also, there will be a lot of sagging posteriorly. And there will be impingement on the ring posteriorly and posteromedially.
And people will come with a cut posterior skin sometimes with the, because of the ring.
Ring.
So, if anybody else has any questions, they can ask, or else we'll move on to the case presentation. Or if anybody would like to share their thoughts.
Yes, when they are expecting, because you can predict which case is going to become more of a edematus, which case is not going to become that much edematus. So we can predict that depending on the damage the patient is having and the surgical damage. In such cases, you can put the ring, not like usually we keep the center board anterior and posterior. So what I do now, I make it horizontal, like center board on the sides. So when there's a edema comes there, I can always extend the ring backwards. Okay, you got it?
Yes, sir.
Make a horizontal way, and you can put a connection plate and increase the anteroposterior diameter of the ring later on, because the mainly pins, you can always play with that.
Yes, sir.
But these are all something which you have to always modify on tape. Thank you.
Yes, sir. Some special tricks some people will follow, sir.
When there are situations, we have to solution, no?
Yeah, true.
Vasu sir.
Yeah.
Yes, sir. One problem that every young surgeons feel in applying Ilizarov frames, especially in the proximal and the distal parts. Proximal parts, many times patient is having pain in the hip while applying pins post-op. Number 2, in distal femur fractures, we are often facing problem of knee stiffness, even if we are applying hinges. What should be the tips for the youngsters to while applying Ilizarov in the proximal fractures or the distal fracture in femur?
In the distal fracture of the femur, the main aim is getting union. And most probably these cases will have a pre-operative, that is before starting itself, they will have stiffness. So the primary aim is to get a union and or maintain the available range of movement. Whereas in the hip joint, if it is an upper femur, there's subtrochanteric corticotomy or something, I always put pin onto the neck.
Any more tips?
Yeah, I always put 2 pins to the neck, like a DHS screw like thing. I put 2 pins into the neck.
Right, sir. Right, sir.
So
Sir, any more tips or Raju sir regarding this?
there's a question from Dr. Nikhil, sir. Is there any specific treatment for lymphedema in the post-operative period that develops? Sir, I think you're on mute, sir. Raju, sir.
No. Lymphedema of what? The foot region, or you're telling about thigh, entire lower limb lymphedema?
I think lower limb, sir. He's just mentioned, is there any specific treatment for lymphedema in the lower limb? I believe, sir.
So, see, lymphedema in entire lower limb, probably you have some vascular problem or there. I don't understand that. Usually, a little bit of edema will be there, but that will be subsiding only with elevation. Yes. We do a lot of elevation work, and moreover, I sometimes keep the patient prone also if the posteriorly, as Prasad sir was telling, they cut the rings, they cut through. We have to warn patients about these things, and then we have to make the patient prone also. That also prone, giving a Krebs support, they'll all decrease the lymphedema. It all depends on the quantum of tissue trauma at the time of surgery. It boils to tissue. Lymphedema will be boiled to tissue trauma.
Yes.
That is one thing, because you have done a good debridement. Debridement is good, and your fixator is stable. It should not have that. If your corridors are safe corridors and there is no vascular insult, then it should not develop these things.
Yes, sir. So if anybody would like to share their thoughts on that, they can. Or else we will move on to the case presentation by Raju Iyengar, sir. Sir, I think we can proceed with your case presentation, sir. So you may share your screen.
I'm doing that.
Yes.
So coming to a case presentation, a young girl of 18-year-old lady had septic arthritis of left knee way back in 2018, for which arthroscopy was done, and she developed stiffness of left knee post procedure, and as usual she was put on physiotherapy, and enthusiastic physiotherapist had done an aggressive physiotherapy and she broke her femur, and that was all with septic arthritis, again leading to a chronic osteomyelitis of the distal femur, that is distal metaphyseal femur. And again in 2020, 2 years later, she developed once again a distal femur fracture, and it was again managed conservatively with above knee cast. And then in 2020, she presented with abnormal mobility with stiffness at the knee joint. This is the radiograph. Now, the problem here is she has a fused knee. She has about 10 centimeter of shortening, and there is an abnormal mobility, and the thigh is extremely painful. This is the radiograph of a 18-year-old female. Look at the appositional growth. The entire appositional growth has stopped. The femur has become like a fibula or less than a fibula at places, and there is a stiff knee with about 10 centimeters of shortening. Any thoughts how to go about it? Anybody wants to take up?
Is there an active infection in the joint or in the fracture site?
The joint is fused now. The joint is fused. There is a bony fusion in the joint, but there is active infection there in the thigh. And there is a pathological fracture also. And the bone is osteoporotic. Actually, she hails from an old city. So, per se, there will be osteopenia, and on top of it, diffuse osteoporosis, and top of it, infective, post-infective osteoporosis. So, all three are there. That is the problem now. And she has a shortening of 9 to 10 centimeter of shortening. Twice debrided, and there is still an active infection there.
So there is abnormal mobility at the fracture site, sir, right now?
Yeah, this is a extremely painful abnormal mobility. There is no frank abnormal mobility. What happens is when there is an infected non-union with scar tissue, the movements will be extremely painful. And whereas if the movements are relatively painless, then there is a fibrous union. That is good for us. But here it was extremely painful. What is more important than that is the osteopenia associated with that. So whenever we are doing Ilizarov, at least there should be some amount of bone strengthening there. Bone should be little bit there, at least they can hold the wires. The diameter of the femur in an 18-year-old female was about 12 millimeter.
Yes, sir.
That is the problem now. So, any thoughts how to go about it?
Infection has to be controlled at any point. Even there is infection at this time.
Yes, sir. That I told you, that there is an infection now also. There is little bit of, you can see the bone ends there little bit sequestrum is there. There is a small sequestra is there. You can see there is a this end is sequestrated.
Yes.
So that is. So my thought was, first thing to go for a union. That is the most important thing. So there was a metadiaphyseal osteomyelitis with a fused knee, 9 centimeter of shortening, and there was, because the lady was not walking from last 1 year, she developed a equinus contracture, because usually will be there. Sir. So this is what I did was, there was a deformity. So
You have removed the dead bone, sir?
yes, sir. Yes, that there was a dead bone. We divided it, we removed it. Now, after removing, what has happened was, you can see. So after removing, Akansha, can you mute?
There is some noise. We should see.
Yourself, sir. There's some background.
Just a second, let me see, sir. Where's the noise?
Just 1 minute, sir. We'll just fix this.
There is some noise from Vasu's number, I think. It's okay, sir.
Yeah. So after the debridement, I already told you that the femur was, there was no oppositional growth from last 2 years. The patient was bedridden from 1 year. The femur has thinned out with osteoporosis and everything. The distal articular segment was broad, and the proximal femur was very thinned out. It was like a lemon on stick appearance. And aligning them together, even if you do some amount of union, it is going to go for a refracture. What I thought was, why not to increase the diameter of the femur by, after adequate debridement, add a fibula and local iliacus bone graft. That was a chance taken, because this girl was bedridden and very prone for 2 times already fractured. And even after applying of Ilizarov, there will be a 3rd fracture, then that will be the end of her. So I added a fibula and also added some corticocancellous bone graft to enhance the union. This is how the patient was walking on immediately post-operatively. You can see there is a good amount of shoe raise, and there is a fibula also. You can see there is a fibula there, a long segment of fibula has been added there, and slowly the patient, for the first time after 1.5 years, she started walking. Then what I did was, then I did a corticotomy. This is the fibula. You can see a long segment of fibula there that is getting incorporated. This is how the fibula is getting, the fibula that is increasing the diameter of the femur in the distal third, because that is the weight bearing axis, and the knee is already fused. So why not to lengthen the tibia to decrease the agony of the patient? Because lengthening there at the femur in a very thin femur, I thought she'll again go for 1 more surgery. And you can see the shank spin. This is a 5 mm shank spin. I have cut this shank spin, and only 12 millimeter of, I am not getting 12 millimeter of shank spin, thread shank spin. So I have to cut this shank spin. That is how I made it and then did a corticotomy in the proximal tibia, because we all know that proximal tibial lengthenings are far more predictable than distal femur or mid-shaft femur lengthening. And this is what I got the lengthening. And this is where the fibula is missing, because this fibula has been transferred above. And this is what the union. She got a knee fused earlier, 2 years earlier only the knee got fused. So that's why we lengthened the tibia, and the femur also got a little bit of width there. The fibula got nicely incorporated, and that is the scar which we are getting. And see how nicely she is walking now. See, that is the hip range. Because of early weight bearing, the hip at least is safe. She walks with a stiff knee gait. That's it. So that's how we could make the patient walk at the end of 9 months without Ilizarov frame, by lengthening the tibia and adding a fibula, so that will give some immunity for a refracture. That is how I managed it. Any other thoughts? Could we have managed differently?
If any of the faculty members would like to put in their thought processes on this before we move on to the questions, which are quite a few. So that was a very, very nice presentation, sir. So the first question is from Dr. Jeevan Pereira. So he's asking, how did the infection in this case get controlled?
Debridement. Yeah. She was on antibiotic and we debrided it. I already told in previous this thing. So this is what the debridement was done. So unless you put a paprika in there, you won't proceed with your Ilizarov frame. Debridement was a key here to get rid of the infection. Of course, antibiotics and isolating the bug and putting her on specific antibiotic is there, but as a surgeon, we should rely more on debridement.
So what was the post-operative mobilization protocol in this patient, sir?
Day one, she has been mobilized because she was bedridden from last 1 year. So most important aspect here should be up and walking. So give a shoe raise and make her walk. Once the limb is aligned, because initially it was in varus position, you align the limb, give a nice stable fixation, let the fracture fragment not move, and you mobilize the patient. Confidence is most important from the patient side. We have to instill confidence and then make the patient walk. Even if the patient are bedridden from last 1 year, they still will be ready to walk. Suppose we make the patient pain-free.
Sir, one question.
Yes,
Just after debridement, did you bone grafting was done in the second stage or in the same sitting?
No, sir. It was done on the second sitting, sir.
Right. So did we put some bone cement like thing with antibiotic beads to deliver the local antibiotics in high concentration?
No, sir. I usually do it, but not in this case.
Okay.
Sir,
That's
there's
fine.
a question from a student. So they are asking that is there any role for using a rush nail across the distal femur into the fibula strut so as to gain more stability in this particular case where the femur diameter is very small?
Yeah. Usually, intramedullary implant will give a lot of stability, but not in this case. It was done because fibulofemoral anchoring with a simple K-wire will be difficult here because the medullary canal was very, very narrow here, and it was all infected. Why again adding some more infection there? So what I did was I passed a wire through that this thing, transfixed that fibulofemoral junction through a wire, so that will give stability to the fibula there. Definitely, fibulofemoral wire, intramedullary wire will give a lot of stability, but in this case, it was not done like that.
Yes, sir. if any of the other faculty members would like to ask any questions or give in their thoughts, most welcome. Milind sir, Vasu sir, Prasad sir.
Yeah, excellent case, Professor Raju. Congratulations. Good job there. Wonderful. Thank you.
Thank you, sir.
Sir, there is a question on what was your protocol for lengthening in the tibia? Like, what was the rhythm for lengthening, sir? That's the question that has been asked by a student.
Yeah, the lengthening is a routine lengthening. Once the patient is up and about walking, so 0.1 mm 4 times a day, that should be perfect. 0.25, 0 mm per day, I mean to say.
Okay, sir.
1 mm per day.
Sir, at the end of the whole 9 months, what was the limb length discrepancy in this case, sir? For this child of 18 years?
No, you can see, Akansha, there is no limb length discrepancy now. The tibia has been lengthened. Actually, when you look at such cases, whenever there is a shortening in the femoral segment, the femur should be lengthened when the knee is mobile. But when the knee is fused, then you can take that as an excuse to lengthen the tibia, because tibial lengthening is predictive than femoral lengthenings.
One thing, it's better to have some shortening, of course, maybe 2 centimeters in this case, better, because the knee is fused, to have better mobility, better movement.
Sir, your point well taken, because she's still growing. Definitely she'll have that shortening. That was anticipated, and then we went for a little bit of lengthening here. That point is well taken, because if we are doing in adult, then there is no scope here. Here you will definitely have that shortening, because the contralateral knee is going to grow.
Yeah. Yes.
Here's a question from Dr. Jeevan. So, sir, in this case, if the knee was mobile, where will the femur lengthening be? The position of lengthening of femur?
In this case,
if it was a mobile knee joint, sir. Yes, sir.
You can lengthen in the midshaft, na? You can definitely lengthen in the midshaft. You can lengthen in even the subtrochanteric area also. It depends on surgeon, depends on the patient, depends on the scarring of the tissue. You have to take that into consideration.
Okay. And Dr. Wilfred Dessa from Goa, he's just asked a question. Sir, please enlighten us on how to put an intramedullary device in a post-infected united fracture of femur.
Come on, please. I didn't get the.
So he has asked, after the infected non-union femur has been united, how can we put an intramedullary device in a post-infected united fracture shaft of femur?
And why do you want to put an intramedullary device? If you are planning to lengthen, or probably for lengthening.
Probably that is the insight with which it's been answered. That is the entire length of the question that was asked earlier.
I didn't get that question. Suppose you are planning for lengthening, you are doing a corticotomy, then you can pass a rush nail or a TENS, something like retrograde or antegrade. You can pass from antegrade. No?
He means there's a persistence of infection, in intramedullary infection, after the fracture got united. Like osteomyelitis, what he mean? It's like osteomyelitis. The treatment should be like osteomyelitis.
And a question has been asked, sir, that can we manage this with all wires and no shank pins?
Yeah, we can manage it. Na? There is a conventional Ilizarov system. They do all wires construct. You have the safe corridor, and then you can manage it. But the problem here is, when it comes to personal hygiene, a ring above especially in the groin area, a little bit on the medial side of the thigh, will be a bit difficult for the female girl.
Yes, I think except in the proximal femur, all work can be done. I've been doing. Yeah. Yes.
So there's a question from somebody who's working in a peripheral setup. So they have asked that I don't have a tapered shank pin 6 mm. So in that case, can I still be good enough to go ahead with a regular shank pin which is not tapered?
Yeah, you can. There is not at all a problem. But the only thing is that when it comes to stability wise, a tapered shank pin works better. And if when you are using a regular shank pin, see to it that it is not stressed too much. Then it will break.
Right, sir. And another question, sir, did you have any post-operative pin tract infection? And if you did have any of them, how did you deal with them, sir?
Plenty. Post pin tract infection, we get plenty. The reason is the patient has to be very committed to take care of the pin site. And I have found one more thing is that when we apply external fixator and we apply a tapered shank pin later on very close to the previous pin tract, then it also gets infected. So always try to be minimum of 2 centimeters away from the previous pin tract and take meticulous care for when you are applying a shank pin, especially drilling, having a very nice sleeve, and then removing the retracting the soft tissues. That will decrease the pin tract infection, but still we'll have pin tract infections and we have to meticulously take care of it.
Right, sir. If any of the other faculty members would like to come in with their thoughts on any of the questions that were raised or any of the suggestions that they would like to give with regard to femur fixation with Ilizarov, most welcome, sir.
I think there is no question. Sir can unshare the screen.
Answer. Yeah.
Yes, sir.
Yeah.
So there's a question that has been asked. They are requesting you to share your insights on any bifocal or trifocal modes of bone transport in femur, sir.
Honestly, I must confess that bifocal and trifocal lengthening not in femur, but in tibia I have done bifocal lengthening. They are easy. But not in femur. Femur, usually patient gets lot of paucity of region rate, and then we have to augment the region rate. That is my experience on femur Ilizarov region.
Bari sir, Vasu sir, Milan sir, would you like to give your insights on that, sir?
Akansha, I can 5th of July, 5th of last month. Can you hear me?
Loud
Yes,
and clear.
sir.
Can you hear me?
Yes, sir.
Can you hear me?
Yes.
Last month, 5th Friday, it was in Friday, probably 5th June, I had a talk regarding the infected non-union, and I have shown there the bifocal and trifocal in femur. If somebody interested, they can see there. You can do it whenever needed. And one case I showed that was the 27 centimeter shortening. I did from the proximal subtrochanteric and below 26 centimeter lengthening I have done, and you can see that one. And it is possible, but sometimes it is difficult in case of femur. But in tibia, all the time we are doing, as Professor Raju said, and femur is also we are doing whenever it is needed. Thank you very much.
Sir, one question, sir.
Yes.
And, in distal femur fractures, the most problem that we see is that knee stiffness after the fracture heals. Do you prefer doing some cortisone plasty after that, sir?
Yes. Yes. And whenever I do the femur treatment, I tell all the time to my patients, you should have to go for knee bending operation that I love to do that. Sometimes I put the Ilizar, go for distraction, and then I do the Judas quadriceps pressly routinely. Routinely, I do that. Judas, it gives very 5-step surgery and it gives very good result. And you can see in the journal also, I have a publication in the American journal, Medcrave, and you can go for that. 5-step surgery. You do the medial collateral ligament, lateral collateral release, then frontal anteriorly release, and TFL tensor lateral release. And if needed, you can go for vastus intermedius, left release. And these are the 5 steps. And rectus femoris is also 5-step surgery you can do. And most of the orthopedic surgeons, I don't know what about the India. In my country, they are not advising this kind of operations, but I do all the time this after doing the surgery, knee stiffness. You must tell your patient that you should have to do that, because sometimes patient comes to our place with 2 or 3 times surgery, and all the fibrous tissue around the knee, it helps to go for this knee stiffness. And to overcome that, you must do this Judas quadriceps plasty. And it is not a very big operations, but you should have to meticulous for that surgery. And it helps even if the movement is 0 to 5 degree, 0 to 5 degree in the knee, you can do the Judas quadriceps plasty. It helps a lot. It helps a lot. And another one, I'm telling you, there is a Chinese publication. They are doing the distraction in the patella first time, the patella, and then they go for this Judas quadriceps. That is called the modified Judas quadriceps plastic. The Chinese, they are doing also. And you can see that publication is also in my, if you put my name and in Medcrave journals of Americans, you can find it there. Thank you very much for asking me the question.
One more thing, just to have to repeat the question. For proximal femur fixation, because you apply pure wire fixation, do you use pins in the proximal femur, and what do you do to avoid pain in the hip for that, sir?
Yes. The original Kurgan, the Russian training that you have seen this time, Shamsuluda, the most of the times, even in fractured neck femur, I go for the this smooth K waves, and sometimes one shunt spins and multiple K waves. Elderly patients, 80, 85, and other with comorbidities, you're gonna do for open surgery, then you can do that one. And proximal femur, basically, we go for 1, 2, or 3 maximum shunt spins, because due to anatomical constraint, you cannot do that. And proximally, you can put shunts. I do proximally put the shunts in the middle and distal. I never put any shunts. And I'm playing only with the wires. And this is I'm doing for the last long years and getting a very good result. Thank you for asking me the question.
I'm doing the same, sir. Thank you, sir.
Thank you.
Milind sir and Vasu sir, do you have any take on that, sir? On
Yes,
that
sir.
question Shamshul sir asked?
About the knee stiffness, sir. Ready, sir? Yeah, Vasu, sir, please.
Yeah. In this particular case, there is no question of knee
Not in this
stiffness,
case, sir.
which is already fused.
Yeah, not in the regular distal femur fracture, sir, with the knees.
Yeah, the primary aim is this. After that, we can always do the cortical plasty. Even that the cortical plasty I do with Ilizarov. I put a frame there with a hinge,
Right, sir.
and I allow them to keep the knee distracted and flex the knee joint with that. So I put the frame. So there's no problem. One day I'll keep the knee in full flexion. The other day I'll keep in full extension. Then patient will be mobilizing it on the frame.
Right, sir. Milind, sir.
And the stiff knee joint in this particular case, I think my choice will be K-waves in the femur. Except the proximal one, I can very safely use K-waves.
I'll come back in some time.
Yeah, and especially in osteoporotic bones, I would like to use more of K-wave than pins.
Right, sir.
Yeah, so there was a question. Yeah, Shamshul. Thank you for asking. It's a really nice program, very comprehensive, I think. So the question is about bifocal and trifocal in the femur. So, this year's VIROC in Bombay Orthopaedics Society annual conference, at the VIROC in the Masala Wala gold medal session, my clinical fellow won the gold medal, Masala Wala gold medal. And the title of his paper was Proximal Femur Lengthening in Post-Trauma Reconstruction. It is an analysis of 115 cases. And the surprising thing we found was that regardless of the age of the patient, the advanced age or the severe nature of the infected non-union in the femur, the bone forms in the proximal femur really nicely. So we have done the series, the average lengthening was 7 centimeters and it ranged from 2 centimeters all the way up to 17 or 19 centimeters. Plus, I think 26 was the largest. So I have never experienced the need for performing a bifocal or a trifocal. And the thing that I found, that my fellows found when they analyzed, we've been analyzing our proximal femur lengthenings in post-trauma in femoral non-unions, is that the lengthening consolidates faster than the non-union. For various reasons, the non-union is the recalcitrant one. And the lengthening is the, it does quite well. As a matter of fact, in 20% of our cases, we develop premature consolidation. And we even were able to analyze the reasons for premature consolidation, with the behavior of the Ilizarov frame and how the direction of the struts can affect it, or, loss of parallelism of the struts. But in general, the premature consolidation occurs because of the extremely high biological potential. And we studied the axial deviation of the regenerate. So that was a paper that won the gold medal in Masala Wala. That's best paper session. And so I've never experienced the need to perform a double level or a triple level lengthening. The lengthening doesn't take too long. It's the non-union which is really recalcitrant, which poses most of the problems, especially in the distal third. That's what I found. So thank you for having me on this program.
And sir, you take one.
I do wish this. I'd just like to finish, Shamshul, with your permission, by saying there's two things. All of us are now very, very good at presentation. It's time we need to create better papers. I do request all of you to read and go through the Journal of Limb Lengthening and Reconstruction. Our own Dr. Srinivas Reddy presented the first, published his paper on subtrochanteric non-unions. That's rare. There's very few, almost no articles in the literature, subtrochanteric non-unions by Ilizarov. So all of us have become wonderful at presentations. All of us have wonderful insights. We're great, experienced surgeons. But how many of us have taken the trouble to be tested by reviewers and editors and get our articles published? That, I think, is the true test. Today, with Zoom, PowerPoint, and YouTube, anybody can go on the web and talk. But I do request to read Journal of Limb Lengthening and Reconstruction. It's jlimblenthrecon.org. It's ASAMI India's journal, and it's the International ASAMI and ILLRS journal. Do read and do contribute. You'll find a lot of tips. And do take up the challenge of publication. I think that's the next level. Every day, every week, we have ASAMI webinars. It's fantastic. There's an explosion of Ilizarovian talent. But I don't necessarily see the explosion of publications with high quality. So that's my gauntlet to all of you youngsters. The next step is to publish and stand the test of the reviewers, tough reviewers, to be able to publish in a scientific format. Thank you for your very kind and patient listening. Thank you.
Thank you so much.
Sir. A lot, sir. Very important for us to.
We will definitely work on that, sir. And with leaders from seniors like you, definitely we will move ahead on those lines. So, Raju sir, one last question by a student. Is there any role of PET scan in order to delineate the amount of infection in and around the non-union site to be more accurate while doing debridement?
See, the best scan is your own eyes. I fully agree with you. PET scan by the standard uptake values, you can delineate infection. There is no doubt about it. But you, by anyway, you are going to open it. You are going to debride it. There is no point in getting a PET scan and spending about 10,000 rupees for the patient. Your eyes are the best scan for that. But yes, the standard uptake values will definitely tell you that this is the area of infection. Infection is not equivalent to malignancy. So that is the most important thing. So if you debride it nicely, then there is no role for any PET scan. But still you can get it done, no issues.
Is there any role of serial CRP and ESR values after the debridement Ilizarov fixation that is done after maybe a month or so, when we are trying to look at it clinico biochemically?
Yeah, the most important thing here is before going to CRP and ESR, it is how the patient is behaving, how much pain he has reduced the pain, or the pain is increasing, or the pain is there. And a simple radiograph will also tell about the quantum of edema present over there. Just by putting your hand over the thigh, you can find that is it really hot, or it is really the thing has become cooled off. So these are the things, and then your low-grade infection or pin site infection also will be reflected by ESR and CRP. So clinical examination for me is more important than your biochemical or hematological test.
And one more question from a student, sir. After the frame removal at 9 months in the last case that you presented, since the bone was osteoporotic to begin with, do you give any teriparatide injections for a follow-up period of?
No, teriparatide is not going to help in this patient, because if you want to increase the bone mass, you have to give teriparatide for 2 years, consecutive years. And second thing, that is not indicated. Off-label teriparatide is being given, but not for young infected non-unions. No, a big no-no for teriparatide.
In older patients, yes, sir. Like probably if they were 55, 60, and with
no. For insufficiency, fragility fractures, yes, but not for post-Ilizarov or after Ilizarov removal or something like that. No teriparatide.
Okay, sir. If anybody else would like to give their insights on that.
Akansha.
Sir.
Yes. My one comment for the young orthopedic surgeons regarding the pathological fracture with osteomyelitis in femur for children. In children, pathological fracture with discharging sinus or pandiaphyseal, whole pathology in the pandiaphyseal region, I never do any kind of debridement. I play only with the wires. And again, I'm telling that I have the publications, and I have shown this in several Indian conferences. Infection, burns, and the fire regeneration. This is the Professor Ilizarov said. It is 100% true in case of children. But for adults, you need to go for debridement. And this is the message. And again, if somebody wants to see this one, you can go for again osteomyelitis. Dr. M.M. you just put and you will see this osteomyelitis. In case of children with pathological fracture femur, completely remodeling, lengthening, everything by Ilizarov without doing any kind of debridement, any kind of touching the fracture area. or discharging sinus area. In children, I'm talking about that one. This is my message. Thank you.
Thank you, sir.
Yeah,
Vasu,
one
sir,
point,
Yes,
Raju
sir.
and all the faculties and participants. Nowadays, recently, there has been an increase in the repair rate. So some people who very bad fixation and rely upon the repair rate. Not only they rely upon the repair rate. So I think absolutely there is no indication of teriparatide in such a situation. So I don't know from where all the pharma people may be behind it. And that's there are many papers are also. Many papers are all cooked up. I don't know how it is reliable. To me, it is nonsense.
Yes, sir.
And we are cheating our own people.
So, Raju sir, one last
Thank you.
question. Finally, thank you so much, sir, for your inputs. Raju sir, one last question. Was there any form of rigid brace given to this patient after Ilizarov removal, sir? Just
Yes,
for
yes, yes.
protection.
Yeah, want of time, I didn't show that images or videos. The patient was on a brace for almost about 3 months. She was on a long knee brace because there was a region rate below and there was a union above. So we gave a brace for her. And that brace she continued for 3 months. Then she was off the brace.
Okay, sir. Sir, on that note, I would like to ask you to please summarize and give closing remarks before we end this wonderful academic session. You
want me
another
to say?
Yes, sir.
No,
yes,
no, no.
sir.
So that pretext, my only suggestion to all my postgraduates and all my junior colleagues is, Ilizarov is not that all difficult, but if you follow the philosophy and principles of Ilizarov, definitely it is rewarding. And at the outset, we all should be under one aim that it is the last, it's a salvage operation. If you can get away without Ilizarov, fine, fair enough. But for infected non-unions, for deformity corrections, and for gap non-unions, and for lengthening, this is the tool which is as of now available for us to do it, to go for it. And always explain everything to the patient, make patient as a party, patient caregivers or the family members of the patient to be a party of it, and expect for a good post-operative commitment from the patient side. Otherwise, it will be difficult. That's all I wanted to tell.
Thank you so much, sir. Shamshul sir, would you like to conclude before we?
Yeah, thanks, Akansha, thanks, Raju sir, for a wonderful interactive session. Thanks all our faculty, Baris sir, Vasu sir, Milind sir, Reddy sir, Prasad sir, Ramaya, and all the young students who participated and make it a very live interactive session. It's making the BIS forum very rocking forum, and we wish all the other states get involved, like Karnataka and Kerala and other states are dragging behind. So we just want to promote all of you to do more of your BIS program besides the basic Ilizarov courses. Amir sir, Reddy sir, request all of you to promote courses, and we are also planning to start some basic online courses also. And just to conclude that, I will come all of you on our upcoming master class series that is on 4th of August, first Friday. And this time, this is on the basics of Ilizarov frame. We have our international Quran faculty like Navikov sir, Dr. Dennis, Dr. Andre, and from India it is the Karnataka State, Satish Necessary is the faculty. So just stay tuned, be online with us on the first Friday. Thank you. Thanks a lot.
Thank you, sir.
Thank you, everybody, for tuning in tonight. Thank you so much for all the senior faculty members who have joined with us. And thank you so much for all the faculty members from Telangana as well who have come online and given your full support. I hope this has been a very, very interactive session for everybody to improve their academic horizons with the best guidance from the best of people who've been seeing and doing and teaching, most importantly. So thank you so much, everyone, for coming in. And thank you so much, Raju sir, for that amazing, inspiring talks.
Thank you. Thank you once again. Thank you one and all.
Thank you, sir. Good night, everybody. Thank you, Bari sir. Thank you, Prasad sir.
Bye. Bye.
Srinivas sir.
Thank you, sir.
Thank
Good
you,
night.
sir.
Awesome. Yeah.
Thank you, Manish. Okay, sir. Thank you, sir. Good night, sir.
Yeah.
Okay.
She can we stop?
Yeah.
Thank you.
Thank you, sir. Good night, sir.
That's it.
Good night.
Bye, sir.
Rishi, are you there? Okay, let me take over.